Hello. Hello, folks. Welcome to another SACPA session. SACPA acknowledges that this event today takes place on the land of the Blackfoot people and the Métis Nation of Alberta Region 3, and we pay respect to their past, present, and future cultural heritage, beliefs, and relationship to the land. SACPA commits to assist reconciliation efforts by raising awareness of the ways past and present injustices can be reconciled. SACPA is very thankful for the continuing support we receive from the University of Lethbridge, Show Spotlight, and the Lethbridge Herald. Today, we're very welcome to introduce our speaker, Dr. Paul Parks. Thank you for joining us today, Dr. Parks. From 2006 to present, Dr. Parks has been actively involved in provincial and national emergency department overcrowding, advocating for important access initiatives and changes. Since 2009, he has been advocating provincially for the open and unfettered ability for physicians to advocate on behalf of their patients, and was actively involved in the government initiated Health Quality Council of Alberta review, which concluded in 2012. This review stated unequivocally that both access block and physician intimidation were and still are significant issues in the healthcare delivery within Alberta. Dr. Parks' advocacy has been honored with the Alan Drummond Advocacy Award in 2011 and the Public Interest Award in 2014. Dr. Paul Parks is currently an emergency physician at the Medicine Hat Regional Hospital and is the president of the section of emergency medicine for Alberta Medical Association, and is presently also the clinical lecturer at the University of Calgary in the Department of Emergency Medicine and Family Medicine. He was the trauma team lead and clinical lecturer at the University of Alberta in emergency medicine as well. Paul is an emergency medicine examiner with the Royal College of Physicians and Surgeons of Canada and is an emergency clinical network member with Alberta Health Services. In recognition of his teaching and resident membership, Dr. Parks received the University of Calgary Clinical Teaching Award, the Canadian Emergency Medical Teacher of the Year in 2007, as well as Outstanding Clinical Teacher of Medical Students from the University of Alberta. Thank you so much for joining us today, and I very much look forward, and I think we all do, we look forward to your presentation.
Thank you. Thanks. Well, that was a fairly long introduction. I wasn't aware that I was going to get the whole introduction, so I can do a nutshell for everybody that all that kind of just means that I'm an emergency physician who works in the trenches in the hospitals. I've worked across the province, so I know what all of the emergency departments and hospitals are looking like across the province. I do wear a lot of different hats, so right off the get-go, I should just make it very, very clear that what I'm talking about here today is my own personal opinion. I'm not officially representing anybody, although I am speaking on behalf of my specialty, and I'm very connected with all of the physicians across the province that are working in the different emergency departments and different hospitals. So I'm some of what I say is sharing their experiences as well. But to be very clear, I'm just gonna try to talk about access block from what it looks like from an emerge physician's perspective in the trenches. And we're in emerge. We see the sins of the whole entire system, and we see that where the system isn't working. And so, just to start off, to get your attention, we're really worried in the emerge departments that the system is broken and that we're in desperate state right now. And so the talk that I want to make sure I leave lots of time for questions, but the talk that I'm going to talk about is specifically around access block. And so what it's really important just to even discuss what that means, right? What does access block mean? And just to start off, it's kind of a catch-all term for saying, you know, when access is working properly in the healthcare system, that means you have the right person in the right place at the right time. And you know, that sounds simple, and it sounds like we should obviously be doing that all the time. But of course, there's a whole bunch of challenges, and there are a whole bunch of bottlenecks, and there's a whole bunch of places in the system that aren't working, that access block occurs. And what that ends up meaning is that you've got a patient, but they're not able to get the right care in the right place at the right time. And there's tons of examples of how that's happened throughout the system and where the bottlenecks are in the system. But one of the reasons that emergency medicine, you often will hear us quite vocally advocating for the system, not necessarily getting out there and saying, hey, we need more emergency departments, we need this and this for emerge. It's a lot of times you'll hear us out there as a big example saying, hey, we desperately need primary care. We desperately need Albertans to have access to family doctors and to preventative care. And why are the emerge doctors out there the ones that are often vocal about that? Is because, as I said, we kind of own the sins of the system where access isn't working. So one obvious example, if patients can't get Albertans and patients can't get access to a primary care physician, then, you know, if they have options of walk-in, that's awesome, but a lot of times that's not even necessarily an option. So they end up in the emergency departments. And to be very clear, we're not, you know, there's discussions about should the patient be in the emergency department? Is that right? Like, is it appropriate that someone gets their blood pressure taken care of in the emergency department or not? That's kind of a moot discussion when that's the only place that a lot of Albertans can access care. And in emergency, we are kind of jack of all trades, so we can kind of deal with a little bit of everything. But that doesn't mean that that's necessarily the best place for it. So I'll be the first person to tell you, you know, doing routine primary care and doing continuity of care and doing the preventative stuff, that the emerge is not the right place. You won't see me every time you come in. You won't have that continuity of care, but we're a stopgap when you need it. But what are other examples that I'm seeing daily now in all the departments across the province? We're now seeing in emerge, you know, failures in access to palliative care, for example, and patients that need end-of-life care and palliative care often have to present to busy, overcrowded, chaotic, crazy emergency departments to get end-of-life care, and that's happening more and more. And again, I'll be the first person to tell you that that's the last place that families and patients want to receive palliative care. I mean, of course, there's times where we connect them with palliative care, and there's lots of appropriate steps. But when, you know, when things are falling apart and they can't get connected or access to community resources and palliative care, and they end up in the emerge department with long waits and with really busy teams that are not designed to do that type of care. So we do our best, but, you know, we see that often. You know, lots and lots of examples: post-op surgical care. If a patient has an operation and then you know, can't get access to their surgeon for days, weeks, or can't get after hours advice, they end up in the emergency department. DI testing, so diagnostic imaging, radiology, people have issues, and, you know, they may be months to get access to MRI or to get specialized testing, and they often end up getting directed to the emergency department because their condition's getting worse and they need help, and they need things sped up. Nobody's disease is static, so over time things change. And a lot of times, like I said, that we're the safety net, where if, okay, that's not working, your access isn't, you aren't able to access what you need, you end up in the department. Another really kind of you know, may not be intuitive is long-term care. Long-term care and home care, we see more and more and more where the system isn't working and isn't working for the patients and their families. Because, for example, if someone is in a scenario where they can't, you know, they're elderly and frail, and they've gotten to a point where they maybe can't live independently at home on their own, and maybe have used up their family resources if they have them or if they don't, and they need home care resources to be safely at home, or ultimately to come into hospital and their condition deteriorates to the point where, you know, unfortunately it happens where people lived independent but got ill and then get to a point where they can't go back independent living, and that access to long-term care and to robust long-term care is often a massive bottleneck that ends up happening on the outwards part of the hospital. So the patients are admitted in a hospital but can't get out into long-term care. And so we see that again and again and more. And then what ends up happening is that's something you'll hear about now a lot in the news, and you're going to see more and more of, is that this idea of admitted inpatients that are patients that need to be admitted into the hospital that end up staying for hours and days and sometimes weeks in a busy emergency department because they can't get admitted to a floor. Like, I could just give you the most easiest example is someone falls down and breaks their hip, and the hospital that they present to, we can see them after a significant amount of time of getting them in, and we can treat, diagnose their broken hip, treat their pain, but then they can remain for days in the emergency department because there are no beds for them to go up into the hospital. It's also, very routine now because we're so stretched that maybe the next bed after days in the emerge is they go to a hallway up in our hospitals. So that's the kind of access block we're discussing. And there's multiple pieces to it, but we just keep seeing it. All of the pieces that are falling apart are difficult. That's what we see in the emergency departments. And I think the one thing why I'm talking about this and why it's important too is that until people access the system, they don't necessarily know how bad it is. So until you need it, you don't know what your experience is going to be like, or until your loved ones need it, you don't know what your experience is going to be like. And unfortunately, we're getting into a period of time now where honestly, the emerge as the safety net of the system and as the canary in the coal mine that's telling how the system's functioning. If you ask my colleagues across the province, many would actually say the canary's dead. It's not having difficult breathing. It's not giving warning signs. It's keeled over and died. And the canary has said the system is not working and things are very dangerous. And so examples I can give you now of what's happening in our departments are, for example, there'll be days where there are, in the bigger departments, in the bigger cities, say they routinely would have about 50 to 60 care spaces that they would take care of sick patients. I'll just pick an example. I'm not picking on one, but say the Foothills Emergency Department will have 55 spaces. There could be any given day now that 30 to 40 of those spaces are occupied by admitted inpatients. So very sick patients that we've diagnosed, treated, and should be up in the hospital somewhere getting dedicated care by dedicated services, but can't go up there because there's no space in the hospitals. And that's the whole piece of access block and right patient in the right place at the right time, because those 40 care spaces that would normally be used to take care of other sick, ill, new emergency patients, those patients can't come into the emergency department. And so then you have a view of midday in one of these, any of the emerge departments where, say, 2/3 of the department is filled with admitted patients that need care and need to be in the hospital, 10, 12, 15 ambulance crews in the hallways lined up waiting to offload into the emerge department. And why is that important? Let me just simplify that. If the emerge ambulance is sitting in the emerge department, if the community ambulance is sitting in the emerge department for hours to offload a sick patient into the emergency department, then they're not available for new calls in the community. So that's another example of access block, where new sick people who call 911 are daily experiencing prolonged delays or absences of response because ambulance crews can't get out into the community and can't get their sick patient offloaded and get back out. And of course, why am I talking this now too? Because everyone listening to me, I'm sure they're saying, well, why aren't the crazy, why do the emerge docs why doesn't the team just offload the patients and let them get back out there? And that's the picture we're telling you, is there is nowhere for us to actually put them. There are no care spaces. There's nowhere where we've added non-traditional spaces of hallways, and we're doing everything we can, but it becomes, so say 2/3 of the department has admitted patients in it, 10 ambulances waiting to offload, and 40 or 50 patients in the waiting room. We get to a period where all we can do is take that next sickest patient when one bed becomes available and put that patient in. And that's the access block we're talking about. And there's any example, you talk heart attacks, strokes, broken bones. Now we're talking about this again because we're experiencing where patients may wait um, 5, 6, 10 hours in the waiting room just to get any care, to get any pain treatment, to get a diagnosis, to get some reassurance. And I should tell everybody right now that none of us want this. None of us go every day when we go into our shift at work. That's not with the nurses, not with the respiratory therapists, allied healthcare workers, physicians. None of us want to make people wait, and none of us, we know that this is suboptimal. We know we need help. And when you get into our system, I think you get some of the best care in the world. It's that getting into the system piece now is becoming more and more difficult. And so what we're seeing now is maybe, I mean, in the intro, we talked about that I had to be quite involved, and a lot of my colleagues and a lot of us were involved in the late 2000s where things were really, really bad. Well, unfortunately now, on a daily basis, my colleagues across the province are telling me, Paul, I think it's as bad or maybe even worse than it was in the late 2000s in regards to access and in regards to how unsafe and overcrowded the emergency departments are. And I keep saying emerge, but I just want everyone to hear that means the whole hospital, the whole system. That means access to family care. That means every piece. But we're just the ones that we can't shut our doors. We can't say no. We have to take the next sick patients, and that's what we're there for. It's as bad as it's ever been, and so that begs the question of what's changed, like what's different. Why are we talking about this more and more now? And I can tell you that there's lots of pieces, but some of the big, broad ones are, after 2 years of the pandemic, there's no question that I want to make it clear that we're not having these difficulties because the hospitals are overflowing with COVID patients. We do have those, and we do have isolation issues, and we do have challenges because of COVID. But all of the things I'm talking about are COVID patients plus very sick patients like strokes, heart attacks, patients with cancer. You name every type of thing you might need a hospital. That's what we're struggling with. And so, but 2 years of the pandemic, it's worn us out. Morale is very low. Our staffing vacancy rates for healthcare workers and physicians are the vacancy rates are the highest they've ever been. Alberta Health Service will admit that we can't fill full lines. We'll find often, even in these busy, drowning emergency departments that I described, there'll be times when there will be some beds in the emergency department that we can't even use because we don't have enough nurses on a given shift. So one thing I want to stress really, really, and I'll come back to it, but stress again, is there's a big difference between what on paper is the capacity of a hospital and what the functional capacity of a hospital is. And functional capacity means you might have a stretcher or a care space, but if you don't have people and human beings and trained people to operate them, then you don't have a functional care space. I'll give you a big example. Across the province, tons of surgeries are being postponed or delayed or having significant impact because there aren't enough anesthetists, there aren't enough surgical assistants, there aren't enough people to operate those hospitals, those operating rooms. And so if you don't have people, you might have an OR, you might have an area where operations could technically be done, but you don't have the functional capacity. And we're struggling with that in our emerge departments because of definitely leftover from the pandemic. But in addition to that, and I should tell everybody, when I advocate about healthcare, I'm not picking on one political party, because whenever there is a government in power, they're the ones that make the decisions and policies around healthcare. And the policies that have happened in the last couple of years have devastated healthcare, devastated the workforce. The government walked in and tore up a contract with all the physicians. They keep telling people that physicians haven't left because of it, but absolutely that's not true. And all the numbers are starting to show that there's been a huge deficit of new physicians are not coming to this province. They're not ready to come into a province where the government has no contract, acts unilaterally, and disrespects and doesn't value physicians. So they're not coming. And so many have left. And that'll take a year or two of a lag to see what that looks like, but we're seeing it now. So that loss of the contract and the way the government treated physicians was massive. But then in addition, they've done the same to all healthcare workers. Like if you look around right now, we just came out of 2 years of a pandemic where our respiratory therapists worked double time. Those are the people. Respiratory therapists are the people that help you with your breathing. So they'll help you with your medicines, put you on ventilators. That's what COVID was for the last 2 years. Those people worked so hard. And what's the government's starting position with them when they're talking to the contract is that you're overvalued. You need a 10% pay cut, and you guys are overpaid. And that's how the government is treating the healthcare workers right now. So, and again, it's this government because they're in power and they're the ones doing the negotiations. I'd say the same if it was another government doing it, but it's been a devastating blow, and nobody, so our workforce is so depleted, and then on top of it, a lot of the unilateral changes that they made that have really impacted care throughout the system. Like, for example, they made a lot of changes around how primary care works. So they really impacted how primary care works in smaller communities, how access to, for example, they put a 50 encounter cap on doctors so that doctors running their office in the smaller areas now no longer can work in the evening to do after hours care or that because of the caps the government just unilaterally put in place. And when I say unilaterally, everybody has to understand when they tore up our contract, they didn't speak to us for 2 years as a profession. They did everything that they thought they would implement and do and never got frontline input. And so they changed how primary care access. So now we have hundreds of thousands of Albertans out there. This is not an exaggeration. Hundreds of thousands of Albertans don't have a primary care physician or any access. A simple example would be in Lethbridge. We know that the number is probably 50,000 that don't have access to it. And now there's no after hours. So my colleagues in Lethbridge, their emerge departments are overwhelmed with sick patients, plus patients that just have no primary care. So, there's lots and lots of pieces that have been added up. Another piece that's happened now is that the government made a lot of changes around after hours care and around hospital-based care, where they kind of unilaterally made some decisions about how they were going to charge overhead for doctors that work in the hospital, despite the fact that those doctors, the vast majority of them, have clinics and overhead and have to run their offices even when they're in the hospital. That kind of amounted to a double charge for those physicians that would do the hard, difficult care in the hospitals. So over a couple of years, it's made a lot of doctors decide that, you know what, I don't want to do the difficult, very, very difficult, hard 2 a.m. hospital care. I'll just run my office. I'll work and see and do very important value-added healthcare, but I'll do that in my office and no longer participate in the acute care system. So there are tons of things that have added to cause a situation where our access block is as bad as it's ever been. And now you're going to see we're going to have to advocate, and you're going to see we're going to have to put human face to what I just said about all that thing, all those, what access block we're going to have to put. It doesn't mean anything to anybody if they hear that every emerge department in the province has 75% admitted inpatients and wait times are on average 6 hours. That doesn't mean anything, but it does mean something when you say, recently I heard of a 91-year-old that had to wait, fell and had to wait like 12 hours to get stitches. 12 hours in a waiting room is like, it's insane and inhumane for any human being. And at a frail 91-year-old, then that patient would be so decompensated that they might even need to be admitted after it because of the wait. It's that kind of thing we're talking about. We really are going to have to stress to put a human face to make Albertans aware of what's going on in our province and aware of why the emerge departments are having really struggling, and why that's a symptom of why the entire hospital system is struggling, and why access block is becoming a very, very, very challenging kind of state for our system right now. And so all that is kind of, I think I'm getting close to the timing in here. So I don't want to be as negative in the sense of what are some solutions? So what are some things, and what are some, that all sounds bad. And I'll tell you from a frontline perspective, our nurses, as an example, they're worn out and their morale is zero. They've been working double time. They've been working short shifted for 2 years. They're worn out, and this access block is just challenging all of our allied healthcare workers. And so a couple things we desperately need is we need transparency. So we need the government to be frank and honest about what's happening in our systems. We don't need every day that they go out there now and say, yeah, our bed capacity is the same as it was pre-pandemic. There's no troubles, when everybody in every of the hospitals, including the HS leaders, are saying, no, our functional capacity is stressed as it have ever been. So we need to have very transparent and fair discussions about what's happening, because when people access our hospitals now, they are often shocked that they're going to be in for a 10-hour wait, and then their loved one's going to go in a hallway. That routine kind of care up in the hospital of like, bathing and certain things that would have been routine when we weren't so stressed gets delayed and put off for days. Lots and lots of things like that the public needs to be aware of it. And then we need, as the public needs to be aware of it, we desperately need Albertans to start to share their stories too, but also to start to talk to their government and let them know that timely access to life-saving healthcare is a priority for us all, and that we need to start to make the government aware of what the struggles are and how difficult it is. And when I say we, it's they, for two years, they haven't listened to the profession, and now they're starting to come back to talk to us in the AMA and start to talk to some of us on the front lines. But in reality, the only people the government's going to listen to are Albertans and the people who are voting. And I'll tell you that now's the time that we need everybody to kind of realize and look around and say, hey, you know what? If you're one of the 50,000 in Lethbridge without a family doc, I'd really be strongly telling you should be letting your MLAs and letting the government know how critical that is to you. And if you've gone through the hospital with loved ones or yourself and have had difficult experiences and suboptimal treatments because of really significant delays or waits or postponements of surgeries, we need you to start talking to the government and letting them know. And we need to kind of add so that transparency is there, so they can't kind of downplay how difficult and how troubling the system is right now. And I think it'll make a difference. It made a difference before the last time we did this. Once we added national and international benchmarks, the government committed to it, and we improved the system. We made massive gains. It was a team effort, and but the government was responsive and actually valued and said, listen, this is a priority for us. And so, I know I'm nearing the end of this because there's lots of other components that we could talk about, but one of the things we have to be really careful about now is the acute care system is struggling so much right now. And a lot of the initiatives that the government are putting in right now, where they're offloading, so the Alberta Surgical Initiative and a bunch of initiatives where they're trying to get care out into the community and into private offices and for-profit offices. I'll just tell you, I'll leave with a note saying that, if they don't do that with guardrails that make sure that the public hospital system is robust and taken care of as the safety net for everybody, if they don't make that acute care system robust and working before they start to offload into the private and community, we're going to find ourselves where we'll have next to no physicians working in the hospitals after hours. We'll be desperate for anesthetists. We'll be desperate for really good nurses, because they'll all have left the acute care system in the hospitals to go work the Monday to Friday, 9 to 5 clinics, and I can't blame them if that's allowed to happen. It makes sense that they would make that lifestyle choice and that they would go. And I'm not saying that they wouldn't provide a service, and I'm not saying that they wouldn't take care of whatever people can be in that stream. I'm just saying that the public system would very likely collapse very quickly behind it, and the acute care system would collapse behind it. So, I think just echo, the system's in trouble. Access block is on like many fronts, and we're seeing it more. But the biggest pieces we're seeing now is access to primary care is critical. Access to after hours care, to be able to get access to specialists and any type of after hours care is critical. It's coming to the point where it's pretty much only into the emergency departments that you can get that access. And then just our workforce and our healthcare workers and physicians and we're going to take years and years to recover in our workforce. So it's at a critical point too. So, that's a 20-year career talk in 30 odd minutes or 25 minutes. So it's a big topic, but I think it's important that we start talking about it as Albertans, because the system is in trouble. And when I say the system's in trouble, it means Albertans that need healthcare are gonna maybe suffer because of it.
Thank you so much. Well, that's quite a sobering talk, I must say. I'm going to jump right into the questions here in the queue. Mark Goddell, with the lack of family doctors, I understand that part of the problem is people using Emerge as a drop-in clinic. Would a drop-in center at the hospital not alleviate such minor visits, such as prescription renewals, etc.?
Well, yeah, so it's complex. That's a complex thing. So one of the things that, having done this for more than 20 years too, is I don't want to get into the game of whether we're, a lot of patients, things that can seem simple, the patients, may think it's minor, like just a blood pressure refill, but in reality, they have very significant chest pain and they need to be in the emerge. So, so it's difficult to say, yeah, it's very clear that there's an X percentage of people that don't need to be in the emerge, and that's causing the problem. No, that is not the case. But I would strongly say 100%. If we had a medical home for every Albertan, and we had a place where they could get primary care and preventative care as a baseline without any difficulty, absolutely, that would free up some capacity and space. But more importantly than anything, there is that would help turn a sickness system into a wellness system where we keep people healthy so they don't need to come see me. But also, not to skirt the question, no question, lots and lots of communities now don't have any after hours or drop-in access as well. So even if they, so as an example, some family practices are so busy that the next available appointment is 3 or 4 weeks. If that's the case, if you don't have urgent access to some type of urgent care option in your community, then yeah, you end up having to go to the emergency department. So it's very complex and difficult. And the long answer, but the one thing I want to just not anybody miss there, when I'm talking about access block and the troubles we're having in the emerge department, it's a bit ironic that when the department is drowning and I'm having a hard time seeing the chest pains and the stroke patients and the ambulance patients because I can't get them in the room, often I can still go out and refill those prescriptions and help some of the easy things. So it's not the easy, simple stuff that's overflowing and overcrowding our emerge department. So yes, I just want to say, having a primary care physician in a medical home is desperately needed, 100%, no question.
Our next question comes from Ian Hurdle. Access seems to be blocked at FPs. Earlier retirement, younger ones leaving Alberta, and limits on daily encounters means no evening clinics and subsequent overflow of ERs. Loss 180 FPs 2021. Comments, please.
100%. We have the changes in the climate and what's happened. I've never seen, most of my colleagues say we haven't seen what's happened in a province like what's happened in the last 2.5 years. With it can't be stressed enough, the government just tearing up the contract. We have no arbitration. We have no mechanism to, we can't strike. Not that we want to. We can't do anything. We're beholden to the government. They just do whatever they want. And they made a lot of changes that really impacted family care in a bad, negative way. And family care tried to say, listen, this is bad, don't do this. And they didn't listen. And I'm not the right person to speak to all the nuts and bolts and ins and outs of the issues of that, because that's not my specialty. But 100%, we have lost many great family physicians that were generalists, that were full practice, that were working in rural communities, often by themselves. They may have retired early. Many have left to other provinces that are actively recruiting them and saying, listen, we value your expertise. And one of the problems now that we're seeing in the line with your question is, like in Lethbridge, as an example, AHS is scrambling so bad that they have to invest $60,000-$70,000 a physician for to try to recruit and get foreign trained physicians over here to try to fill the gap that the government created when they made changes that chased them away. And I'm not criticizing whether the foreign trained docs are good or bad or will fill the gap. I'm just saying that that's insane to lose the good resources that we had, that we trained, that we were in the communities, chase them away, and then scramble and spend tons and tons of money to get new ones in. It's crazy. It's not a strategy that anybody would suggest would be reasonable. And unfortunately, that's where we're at. So no question, just physical bodies for physicians and for nurses is a massive challenge. It's going to challenge our province for years.
The second question by Ian Hurdle. Canada now has one of the lowest hospital bed ratios to population in OECD countries. So even if there were more beds, staffing would be even worse. What are your comments?
100%. Like, that's one of the issues we're struggling with now, is that there are, even when the hospital's at 130% capacity, we have some wards where we're not using every bed right now because we don't have enough staff. We're trying to fix that, trying to create that. But yes, it's a two-pronged thing. If we don't have nurses, if we don't have nurses aides, if we don't have respiratory therapists, every part of that, it's not just physicians, of course, like, it's a big team. If we don't have them, if we don't have physical bodies and human resources and people to do the caring, then there is no health care. It's just, so that's one struggle. Two, though, is the bed base is an issue. The bed base for long-term care and getting patients out to there is a massive issue. But, I don't have the stat in front of me, but I just saw, I think we're just in for a tsunami of elderly patients in Canada now too, where there's going to be a huge percentage, 1/3 of the population over X, whatever the number is, 70, I don't know what it is anymore. But the whole point is people are living longer with complex diseases, and we're not going to be able to function with the lowest number of acute care beds and long-term care beds. It's going to just keep on bottlenecking and causing access block to get worse. And 100% staffing, and physical beds and appropriate beds for the right patients. And I'll give you an example that's really, really tough. Is we just went through 2 years of the pandemic, and one of the most critical phases in the fourth wave is we didn't have we were stressing our ICU capacity to the beyond max. Unfortunately, the government, I'm not sure what advice they got, but they decided they needed to get us a whole bunch more ICU beds, when in reality, we actually have a fairly good bed base for ICU across the province for normal operating times. And then if you go and surge that up, we're going to have lots of really skilled critical care nurses to work in ICU beds that may not ever be full. And we don't necessarily have them to work in the emergency departments or on the hospital floors. So we desperately need the policymakers to start listening to the frontline experts as to what the system needs. And that's been missing for the last 2.5 years.
Next question. How does one tell a fascist to stop being a fascist? This is a government that has consistently gone out of their way to disrespect experts. What are your comments on that?
I think, my personal is truth. So you gotta get the truth out there as my personal, and that's why I think transparency and letting everybody know what we're facing and what's happening, and patients telling their stories, getting that out is going to help. But again, that's why I said in my talk that I'm pleading to Albertans is that, I'm trying to formulate relationships with the government, and I'm trying to get them to listen so we can tell them the truth. But and hopefully that'll turn around. But if not, the government is beholden to the public, and the public the voters have to express their concerns. And I'll just give you a really example. I'm the president of emergency medicine for the whole province, and we just had a once in a century pandemic, and it was over 2 years before the government invited me to the table to talk to Dr. Hinshaw and the Minister of Health to ask for the emerged perspective on what we should do in the pandemic. That's how broken our relationship has been with this government. It's insane. I mean, despite myself or any of my other emerged colleagues and experts begging to please talk to them and discuss, and the AMA trying to do it as well, that's how broken it was. So I think the first step is we all got to speak truth to power, and that's one of the challenges we have too. They changed our college. They threatened physicians. This government's actively tried to bully and muzzle physicians, and so I'm just that's why I'm at talks like this. That's why I'm trying to talk to people and say. I think it's part of my duty to advocate for my patients and for the system. So not just my patients, the system, right? So
Our next question comes from Beth Mundell. Are medical doctors and nurses who have so bravely worked these last 2 years now thinking of leaving Alberta?
many have. So unfortunately, yes, many have. Like many have retired, many have switched from difficult, very difficult, high acuity, critical kind of care to do other types of care so that they, can ease the stress that they've been under. So yes, like we've been seeing that again and again and again. And I can't, that's one of the pieces that I can't say again is like strong enough is that if you don't value your human resources and if you don't start with a position of saying like, that we really truly value your expertise, your skills, and you doing the job you're doing, then if they don't feel valued and their morale and they're stressed and everything on top of it, and then a starting position is, like honestly, if you look at the starting positions of negotiations with social workers, with respiratory therapists, with nurses, it's like and sure there's some politics to it in negotiating, but that's just an example of the attitude of how we've been treated by this government. And when I say we, it's mostly the allied healthcare professionals and of course physicians. They just haven't even talked to us. So yeah, lots and lots, and I know tons, and I'm hearing more and more are leaving. And I'll just give a really good example. Our brothers and sisters to the west in BC, they're desperate for family physicians. They're desperate for healthcare workers and nurses, and they're trying to encourage us to come over there with open arms. They're recruiting us. They're like, come, we have a stable contract. We have this, we have that. We want you. We respect you. We value. People are going to leave and go to that. So that's what we're faced with right now. And I'll tell you, ask AHS, our AHS leads are been very open and frank, saying that our staffing levels across the province are historically the worst they've ever been for allied healthcare workers. So we're in for trouble. It's going to be difficult.
Our next question comes from Leona Jacobs. What is the estimated cost of after-hour drop-in versus the estimated cost of an emergency visit? Also same question, but a primary care visit versus an emergency visit, really.
Well, so that's kind of complex in that Emerge. So Emerge has a whole bunch of fixed costs and overhead and a whole bunch of costs. So it's definitely more expensive overall for care to be done in the hospital that doesn't need to be done in the hospital. So that like if they could see a family physician in the community and that was appropriate, it's definitely more expensive to come into the hospital. You have more fixed costs because of just registration, just everything. But that being said, it becomes where there's this kind of diminishing returns where if you have a urgent care center or an after hours clinic that's working very well and efficiently and can keep numbers through, then there becomes a point where they can see people more efficiently and more cost effective because they're kind of designed to do that. But all that being said is that it's not, I wouldn't say it's as much as it wouldn't be the comparable of cost of me seeing someone with blood pressure and needing a blood pressure pill and in the Emerge and someone seeing it at their family doc. They're similar. The bigger issue is that usually by the time they come see me, it's been so long or they haven't had really tight control of all the issues they need, that their disease is a lot worse and the cost to society is massive because of that. So because now maybe they're having, obviously there's like having heart attacks and strokes because their blood pressure wasn't managed for a long time or their diabetes wasn't or whatever. But and more we're seeing, for example, after this 2 years in the pandemic, lots of delayed diagnoses of like cancers. And so it's very obvious, everybody knows this is not debatable. If we can detect something before it becomes a cancer and treat it or treat it really early, before it spreads to the rest of the body, there's life-saving and massive cost savings to that. And so preventative medicine is always going to be cheaper. And that being said, you're always going to need to come have emerge departments for when you have a motor vehicle collision, when you fall off the roof, when you have a heart attack. There are acute things you can't predict and you need us. But preventative care is always going to be cheaper and better in the long run.
Next question is from Bridge City News. Here in Lethbridge, there's only one clinic accepting new patients, and then in brackets, the opioid dependency clinic. And a ton of people are going to the emergency department to seek a doctor. You mentioned reaching out to local MLAs to see what they can do to fix the problem. How confident are you that this will work, and what else can be done? And then in brackets, Lethbridge bringing in sponsored doctors?
Yeah, I mean, so, and just to be clear, Lethbridge is probably like one of the worst scenarios for family physicians, but it's similar in a lot of communities. Even in Medicine Hat now, we're starting to see where, when patients come in without a doctor, I think there's maybe one in the community, and I'm pretty sure that physician's full. So we don't have doctors that are accepting new patients anymore either. So that's just an example. It's happening in lots of communities. Your community in Lethbridge, very big challenge, 100%. And so a good example, like I said, is some of the unilateral changes the government made. I know that my colleagues that are in primary care that are super busy and already have super full panels that stayed in Lethbridge and are working there, A, they're just too busy to be able to take new patients. B, the changes made it so that they can't, there's no incentive or even, financial. They don't get paid basically to work after hours and take care of unattached patients, say if they work their clinic all week and work evenings to take care of unattached patients. So those changes by government totally impacted that ability to access. And then from an emerge perspective, I can tell you that my colleagues in emerge in Lethbridge will do their best to help people that come in, even despite knowing that the merge isn't the best place to do primary care. They'll do the best that they can, but those patients will often come in with complaints that aren't as urgent or emergent, so they'll wait long times. Their waits will be hours and hours. And then the other piece that needs to be highlighted is that they then will be discharged out of the emerge department with no family physician to check up on them again, with nobody to see. A simple example: you come in to see me because your blood pressure's high, and I start you on a blood pressure med. You need to see a doctor again to see how that medicine's working. Does it need to be titrated up, down? Do you need to do other things? And so that's a challenge in Lethbridge, as an example, is that they can diagnose serious things that need continuity of care and need a family physician, and they know they don't feel good about discharging that person back to the community and not being able to connect them to primary care. So it's a massive issue. And so then how do you correct it? Two things. One piece, it baffles my mind that the government and, the Minister of Health and the Premier aren't held to come down to Lethbridge and come see what actually it looks like when there are no family doctors. Like 50,000 people without a family doc. That's important. Like, so in that number, are there lots of healthy 20-odd-year-olds who don't need a doc and don't know they need one till they need one? Sure. But I'm certain there's a large percentage of patients in that group that desperately want a family doc and are suffering or having difficulties because they don't want one. So back to transparency, the news, like yourself, patients, people, they need to be talking about this. They need to be advocating about it, and they need to be pushing the government and saying, what's your solution? What are you going to do? And then they need to be holding government account too. Is it really wise to chase away all the docs we had, do unilateral changes, do these things, and then have to throw lots and lots of money to recruit doctors into that area when you don't necessarily know if they'll stay? They may, and they may come for 2 years and then leave after their 2 years are done if they're foreign physicians that need to come in on a return of service. So the whole point is, I'm not saying being critical that won't work. It will help, but is that really the way we want to do it? Is like blow up the system and then try to patchwork, fix it after the damage is done. So again, you need to talk to my primary colleagues, like my primary care colleagues, routinely about this. But Emerge will happily talk to you too, because we will be the first to say we can't do primary care and preventative care in the emergency departments, and we desperately need that component, and we need Albertans to fight for it, and we need the press to talk about it, and we need the communities to engage and advocate for it, because that's ultimately what the government's job is.
Our next question comes from Laurie Schultz. Is the government, and in brackets AHS, applying the lean method, i.e. timing the interactions between a healthcare worker and patient/client, contributing to the deterioration of acute and primary healthcare?
Well, I don't know. So one thing that people don't know necessarily intuitively about our system. So Alberta Health is the government that sets policy, and Alberta Health Services is the operational arm. That's a one body throughout the province that delivers the services. And one of the problems that we've had more and more and more now that I can speak to is that AHS is no longer really arm's length from Alberta Health. It's just purely it gets marching orders and it goes out and marches and tries to do them. And there's been a disconnect at high levels of AHS necessarily coming back to the government and saying, this thing you want to do will cost cost more money and will impact care and will be bad. That chain and that kind of arm's length and feedback is broken, absolutely broken. And so, and as a prime example, firing AHS's CEO, Dr. Yu, is a perfect example of how broken that is, because Dr. Yu is who, at the top, who knew what was going on in the operational arm of healthcare, and was very much trying to tell government some things that maybe they didn't want to hear. And now she's gone a year early with no replacement, because I'm not too certain that the government wants to hear from the expertise as to what should be done. So I can't speak exactly to the lean components and drivers, but I can tell you that the disconnect of having the operational arm not be somewhat arm's length from the policy making has been very, very challenging and problematic for our system, 100%.
Our next question actually touches a little bit on what you just said, but I'm going to read it anyway. Belinda Crowson, I've spoken with several AHS workers from many different fields, and they feel angry and abandoned by the firing of Dr. Yu. Do you think the loss of her leadership will exacerbate the issues?
Personally, 100%, I think it will. I think that so again, I said through my talk, one of the solutions is transparency and truth, and saying what the system is like, and being honest and frank with Albertans of what it's like. And I think Dr. Yu really understood the system, and I'm certain she understood what two really, really, really hard years. That's a lot of hard, really. It's like 2 really bad years of the pandemic, what it did to our system and how much it challenged it, and what added stressors it added to our system. And then in addition to what the policy changes and the things that happened over those 2 years. So I'm having communicated with her, worked with her, and I'm positive that she was knowledgeable and aware of what some of those big challenges were. And now to have her gone without really a replacement midterm, as we're coming out of difficult pandemic and really challenging access block, is definitely very bad. And in addition, it's going to be very difficult for the system, but it also signals, I would think that it signals the government wants somebody that's going to tell them what they want to hear, as opposed to what they need to hear, or what the actual objective situation is, as opposed to just saying yes sir, we'll just do that, and not feeding them the problems that they would anticipate with the policies that they're making.
Our next question comes from Ian Hurdle. The first match for training this year's family physicians did not fill 32 spots in Edmonton. Does that mean Alberta is not attracting or attractive to Canadian grads?
I think it speaks for itself, but yes, and I would tell you that right now, so I do a lot of teaching, I interact with a lot of residents, and I'll tell you that the uncertainty of how this province's government and policymakers are treating physicians is really a major impact on learners. Nobody is going to want to spend the years and the hard work and the training that we have to do to go through to become physicians, to enter in an environment where in the simplest terms, I'll be really blunt, where your input and opinion as to your work environment is completely disregarded, and there is no ability for you to give that input. So your actual professional body, the AMA, doesn't even have a relationship or a contract. So your input's not wanted, and there's no way to give it. So you have no control over your environment. You have no ability to in any way arbitrate that if what you're seeing is difficult or challenging. You also have college that's been under attack, so that we're not self-regulated, and they're actively trying to muzzle. The government wants college and wants to muzzle physicians who are advocates and who are trying to advocate for the system and the patient. So there's no question, talking to grads and physicians and early physicians and students and people that are out there trying to choose where they want to land. This province is too tumultuous right now, and it's not. And so and I can simplify it even more, because I'm not an expert in the higher education in regards to PGME and postgraduate medical education. We should be hearing from them too, but I can tell you that the training hasn't changed. So the residency positions are not like, it's not like there's poor teachers or you're not going to get a good experience. The training and the work environment of learning has not changed. The environment of where you're going to work and what your workplace control and input's going to be like has massively changed.
Our next question comes from Mark Goodall. Could you say a little something about what is happening in the rural hospitals and their ability to accommodate and treat their patients?
So same thing. Everything kind of trickles down as a scale, but the same issues is that you have to think too that in the smaller hospitals, so they have less resources, obviously, and so they have their own unique challenges. But as they struggle with staffing, and as they struggle with real worn out teams and just personnel struggles and all those things, that becomes amplified even more. So if you're working in a hospital at where the wards where maybe in the foothills there's 12 nurses, and then Medicine Hat there's 8 or 6, and then in a really small hospital there might be 2 or 3 in the ward. Losing one of those staff members on any given shift is obviously a much bigger impact and much more difficult. So they're struggling with that with their teams, and then of course they're absolutely struggling with just recruiting and retaining full generalists that will do full service, the entire spectrum of primary care and working in the hospital. That's a very difficult job, and if it's not valued and if it's not supported, you'll have a very hard time getting anybody to enticing people to go into those positions. And I can also tell you that it's also very, very challenging that if you're bringing in foreign trained doctors who don't know the community, don't know the people, don't know the culture, a lot of those things, that just adds another challenge to it as well in those small communities. So I'm not saying that it doesn't work to bring in foreign trained grads. I'm just saying that it's a challenge on both sides. So rural is a lot of the changes that happened in the last couple of years have had a really disproportionate effect on the rural care physicians. So they're really struggling. So of course, in Medicine Hat is a good example, is we get fed from a lot of the rural, smaller areas. And so we're routinely seeing now, no coverage in the hospitals, no coverage for family physicians having to send patients up to us because they can't admit them into their hospital because of staffing challenges. Like that's a daily occurrence, and that's part of the access block I'm talking about. It's that system-wide exact problem, and we're all struggling with it to varying degrees.
Our next question comes from Laurie Schultz. The UCP has been upfront on their goal to privatize healthcare. Are the UCP policy decisions and actions merely a strategy to burn the public system out and start building a private system?
Well, there's the worry of that. The system is burning out and it is in trouble, and but I would think that we have to be, again, I'd fall back to the only places where private and public have worked maybe to a degree, and you could look at it in some of the places like the United Kingdom, Australia a little bit. There's lots of evidence, and it's a whole talk in itself, as to whether you could have a private stream work and have it work with a public stream. But the only comment I'll make for everybody is that in any of the places where it may work, and you have to have a robust, really well functioning public system. And our system is as far as you possibly can get from a robust working public system at this point. And just to simplify it as simple as you can, so maybe there's a long waiting list for knees and shoulders to be operated on. If you just take my community of Medicine Hat as an example, and you say, go ahead and let's have a private clinic open to do operations on knees and shoulders because they can be done in a day and don't need hospital admissions. Well, what that means then is you lose one of your orthopedic surgeons, leaves the hospital and goes and does that. One of your anesthetists and a couple of your best nurses, all-around nurses, leave and go into that private stream, whether it's funded by public funds or by the patient. They still left the stream and left the hospital. And one of the things that I'll strongly say that we all need to be kicking and screaming now is the government is doing this right now without guardrails, saying, listen, if you leave and do work in a private clinic or work in a outside of the hospital stream, you still need to have privileges in the hospital. If your patient has a complication, needs to be admitted, you still need to do some hospital care to take care of all of the complex patients and trauma patients and people that are admitted to the hospital. We need guardrails. I have my own personal opinions as to what would happen, if they let the floodgates open. But my professional side right now, 100%. I think a personal and professional, I think it's not a great idea. But from a professional point of view, I'll tell you, our system without robust public healthcare system and without guardrails as to what will happen, rules and regulations and guardrails, which are not in place as the government's implementing this right now, the whole system's going to collapse. You'll have a scenario where the healthiest, easiest cases will be done in the community, and when they have complications, they'll be dumped back into the hospital system with nobody to take care of them and no safety net that's been kind of set up ahead of time to take care of them, and it'll be disastrous. And so we have to be very, very aware of that. And so is the government actively trying to destroy the public system to set that up? I sure hope not, but if that is a concern, we should be kicking and screaming, I think.
Excellent. Well, thank you. Before we wrap up this session, do you have a take-home message for the viewers today?
Like the biggest, simplest thing I'll say is please get vocal, like transparent, and talk about talk about if this is important to you. Talk to your MLAs, talk to your government, talk to the newspapers. So when you have bad experiences, one thing I urge patients when they wait long times and they have a bad, suboptimal outcomes, I say, listen, it's not critical of me if you're upset that you waited 12 hours and then your loved one had to go in a hallway in the hospital when they had to get admitted. It's not critical of me in the system, because none of us want that. We want a system that functions for our patients. It helps us when you tell those stories to the government, when you tell them to the press, when you let people know what that experience is like. And it helps us when you get kind of vocal and demand transparency and support us. That's the help that we need. And we need like I said, we need engaged Albertans everywhere to tell the government they really prioritize publicly funded, timely healthcare and a public system, because it'll be gone before we know it. And then when you get sick and go to access it, it won't be there, and it'll be too late. So that's why, just getting vocal and having talks like this and getting active and supporting it before it completely falls apart.
Thank you. And I actually want to read out some of the thank yous in the queue. Bridge City News, thank you for your presentation. I appreciate the information and also your beer at the Hell's Basement, especially the fruit bat raspberry ale.
Nice.
Ian Hurdle, you should know, even with the contentious issue, that the doctors whom you have been preceptor for think, I'm messing that up, sorry. You should know, even with this contentious issue, that the doctors whom you have been preceptor for think you are awesome. including one of my children. And Lori Schultz, Alberta have and approached their MLAs. MLA's response is an elevator speech or speaking points. So thank you from Lori Schultz as well. Thank you for your clear presentation for someone who's working in the trenches by Beth Mundell. And the thank yous actually just go on. So people really appreciate it. And on behalf of SACPA, thank you very much. Folks out there, I hope you'll join us next week. Dr. Chris Burton, why did Russia invade Ukraine in 2022? The history and contemporary causes of that war or the war. I hope you'll join us for that. And with that, we'll end the live stream.